Hi friends, good evening all. Today I would like to discuss about basic management principles of fracture. Regarding basic management principles, it include 3R: reduction, retention and rehabilitation. Otherwise, these three questions: is fracture position acceptable or does it need to be reduced? This is very important in fracture OPD setting. Is fracture position acceptable or does it need to be reduced? If there is no displacement, then no need of reduction. This is the basic point. If there is no displacement, then you don't apply traction or counter traction to that particular affected part, as it causes other complications. So, is fracture position acceptable? Then no need of reduction. Otherwise, it should be reduced. Regarding dislocation, the first thing to be kept regarding dislocation is check an X-ray to find out whether there is fracture. If there is fracture, then surely we should avoid attempting reduction. Otherwise, it may cause damage to the affected joint. If there is fracture along with dislocation, then you should not attempt reduction. This is the second thing. The other question to be asked, the first question is to be find out whether there is reduction needed or not. The second question is fracture stable or does it need to be held? Whether retention or immobilization or bandage is needed in this particular condition. This is the second question. And the third question, when can the patient begin to use and move the limb regarding rehabilitation? It can be precisely, we can call it as reduce, hold and move. And this movement is very important and it should be judicious and it should be it should start from the very first day of consultation itself. The rehabilitation should start from the very first day of consultation itself, even if it's an injury. I will explain more regarding rehabilitation at the time of rehabilitation, explaining rehabilitation. This is the basic principle: reduction, retention and rehabilitation. And first two is to be added only if necessary, but rehabilitation always necessary. This is the basic point regarding basic management principles. Coming to the reduction, reduction includes traction, counter traction and correction. Traction, counter traction and correction is the principle of reduction. In Susruta Samhita, Ada Avanadam Unnamir, Unnadam Chava Bidayat, Anje Adishiptam, Adogatam Chobarivartir. This particular verse is regarding reduction methods. And regarding reduction, first you should keep in mind reduction techniques are highly specific and it should be done gently. To each particular displacement, it is specific. To each particular joint, it is specific and it should be done gently. Before and after X-ray investigation is must in all reduction methods. If it's a dislocation or if we are reducing a fracture with displacement, in all conditions, before and after X-ray is must to check whether our reduction is proper or not. In Colles fracture, immediately after the reduction, we should take one check X-ray. On the first and second review also, we should take check X-ray to ensure our reduction is proper and further displacement doesn't occur. So that it is must. In all conditions, before and after X-ray is must, and as per specific conditions, it should change. This is regarding reduction. Coming to immobilization, we can use three techniques for immobilization. One is external splintage, what we are doing. Our method of immobilization is with external splintage. Second one is internal splintage. Orthopedic surgeons are doing this particular technique in needed cases. Internal splintage is not needed in all cases. If conservative line of management or closed manipulative reduction is not possible In such conditions, internal splindage is needed. For that, K-wire or plates, such things, metal screws are using for internal splindage. Third option is continuous traction. In femur shaft fracture or tibia fracture, we are using this particular continuous traction method. It can be either bone traction or skin traction. This continuous traction is a method of immobilization. These three techniques can be incorporated as part of immobilization, in which we are using external splindage. Coming to immobilization, various modalities are used. It includes bandage, splints. We can use bamboo splints or malleable aluminum splints or metallic splints. Or you can use wooden splints also. I am actually using aluminum splints which are malleable, which we can change the shape according to affected joint. Then POP slabs, that means half cast bandage, and complete POP cast. Internal fixation, which are surgical, and specific regional orthosis can also be incorporated. If time permits, today or on next week, we can discuss regarding specific regional orthosis also. As per the convenience, we can use these techniques, but bandaging techniques is more specific and more important than orthosis, but in such some conditions, orthosis are better than bandaging. We can discuss that particular conditions. Coming to bandage, this is the definition of bandage. It is not needed. We can discuss in detail about Susrudacharya's bandaging techniques, which he discussed in the 18th chapter of Sutrasthana. We can discuss about Bandhana Vidhi of Susrudacharya. Uses of bandage include to stop bleeding by pressure, actually to compress, to stop the bleeding, to arrest the bleeding. We have Rakta Stambhana bias, but the ideal technique to stop the bleeding immediately, the technique used is compression bandage. Compression bandage is very effective. And coming to injury, to give rest and support to the affected part, to retain dressings and splint in position, to prevent edema or swelling, to cure deformity. These are the uses of bandage regarding injury management. Coming to the basic principles of injury management, it includes PRICE. P for prevention, R for rest, I for ice, C for compression, and E for elevation. PRICE includes P for prevention, prevention of injury, R for rest, then I for ice, Shida Prayoga. For that we are using Murivanna. In the initial period of injury, there will be hematoma formation due to the fracture or due to ligament sprain or muscle strain. Bone is highly vascular, so the hematoma will be more, so that there is a chance of Shoidur Bahulyam in Bhakna Samanya Lakshana. And due to this hematoma formation, there will be Pitta Raktakoba. To subside this Pitta Raktakoba, Shida Prayoga is advised. Delana Tika explains about Shida Prayoga, Pagadi Pariharartham, Sandanartham. Shida Prayoga is for Pagadi Pariharartham and Sandanartham. Instead of ice, we are using Murivanna, and this soft tissue edema or soft tissue injury due to this hematoma formation will subside by the usage of Murivanna. That is the principle of usage of Shida Prayoga. And the fourth thing is compression, that is bandage. And fifth thing is elevation. Elevation in upper limb, we are using a sling or Ulsangi Bandha. In lower limb also, we ask the patient to elevate the affected part to reduce the swelling. I want to ensure one thing. The first principle, the first thing to be done in injury is immobilization, not Labana. The first thing to be done in injury management is immobilization, not Labana. Even if there is swelling due to this particular injury, the function of immobilization, the use of immobilization is to reduce the edema and swelling. For that, don't go for any Labana or Nagaradi Labana in the initial setting. Immobilization is best. Why? Because to prevent the movement of that affected part, immobilization is very much important, so that the first principle to be incorporated in injury, in the initial phase of injury, is immobilization. Don't forget, as we are practicing Shalya management, as we are managing orthopedics, this is very important. I saw some Shalya people are giving Nagaradi Lebana in the initial phase and then they are going for immobilization, but that is a wrong technique. As per my gurus, the first thing to be incorporated in the initial phase of injury, the first thing to be done is immobilization, not a Lebana. This is very important. To prevent the edema and swelling, we are using this compression, bandage, and then elevation. In upper limb injury, from the sternoclavicular joint to the distal extremities, it is a sling should be applied from the very beginning itself. Before examining the patient, you advise or give a sling to that particular patient. If you are sending the patient for X-ray, the patient should be, the affected hand should be in sling, and then send the patient to X-ray. This is very much important, so that the patient felt good comfort in this sling. So that to prevent edema and swelling, we are giving immobilization and then we are giving elevation. So that our principle is that first we should immobilize the patient.
Sir, can you please explain the point once again, sir?
Excuse me?
Sir, can you please explain the last point once more?
Okay. Just before sending the patient for X-ray investigation, if upper limb injury is affected to the patient, you should advise to wear a sling and then send the patient to X-ray. From the very beginning itself, before the immobilization, give a sling, a simple triangular sling as a first aid. In all upper limb injuries, our primary aim, our first aid should be application of a sling or ulsangi banda or triangular sling. This is very much important. And if you are advising X-ray to that particular patient, to a patient with upper limb injury from sternoclavicular joint to distal extremities, you should advise or ask the patient to wear a sling, and then that patient should be sent to X-ray. This is regarding first aid management of upper limb injury. And immobilization is the first technique. Then second thing, elevation is must in both upper limb and lower limb injury to prevent swelling, to reduce swelling. Coming to the types of bandage, Susruta Acharya explained in Sutrasthana 18th chapter, Koshadama, Sostiga, Anuvelida, Pradoli, Mandala, Stagiga, Emaga, Katwa, China, Vibanda, Vidana, Gofana, Panjangi. And Vagbada Acharya included Ulsangi Banda as the 15th Banda. Charaka Acharya divides the Banda into two, that is Vama and Dakshina. Actually, when coming to the roles of bandage, it is explained like this: the bandage should be from inward to outward. Bandage should be from medial to lateral. So that if we are bandaging to a patient's right hand, then it's from medial to lateral like this. And when it comes to left hand, medial to lateral will be just opposite. And this is the basic division told by Acharya Charaka. This is Dividha Banda, Vama and Dakshina. Coming to specific bandages of Susruta Acharya, Kosham is Kosham Angushthanguli Parvasu. We are using this particular bandage in interphalangeal subluxation or dislocation and fracture of fingers. Actually, this is Kosha Banda. For this purpose, it is better to go for orthosis. I will explain orthosis later. In this condition, orthosis is better than this particular bandage. This is compressed cotton or top band. Compressed cotton or top band, soft cotton. Mainly we are using this for casting. Actually, this is Koshabanda. We can use a finger cord or frog splint instead of this particular bandage. Never use other finger as a splint. if there is injury to this particular finger, never use this finger as a splint. Two skin surfaces should not be bandaged together. We can use just a piece of cotton covered by a gauze in this particular area, but that technique is not much good. Why? Because if there is injury to this particular finger, after 1 or 2 weeks, this is very important. In fingers, 1 maximum 2 weeks immobilization is only to be needed. After 2 weeks, you should definitely ask the patient to do rehabilitation in fingers. As fingers are more mobile, the rehabilitation is very important. The functional outcome is very important. So that ask the patient to do the rehabilitation even after 2 weeks, even if there is pain and tenderness. Ask the patient to do the rehabilitation to retain or to maintain the movements. If we are using the other finger, then we should do rehabilitation to that particular finger also. That particular finger is normal finger. If we are using that particular finger for bandaging, then we want to rehabilitate that particular finger also. So that this is a basic principle. Never use the second finger as a splint. It is better in this particular condition. Actually, this is Koshabandha. It is better to go for finger cord in this particular condition. In such conditions, in some conditions, in mallet finger, I will explain that. In mallet finger, mallet splint is better. Why? Because 6 weeks immobilization is needed. In mallet finger, only these 2 joints are immobilized. Up to here, the patient can move. This particular part is only immobilized. So that such orthosis are very effective, better than bandage. Coming to Dama, Dama Sambade Ange or Sangade Ange. The Sambade Ange, the Tika is Sangade Ange. And I will tell you what is actually Dama. I will tell you after explaining the Swastika Bandha. I will tell you what is Dama Bandha. Swastika is, all of us know, Sandhi Gurchaka Purustanandara Talakarneshu Swastika, figure of 8 bandage. The bandage which we are doing to a joint is Swastika Bandha. And this Anuvelidam is spiral bandage which we are doing in limbs. Shakhaso Anuvelidam. Shakhaso Anuvelidam. I will show the video of Anuvelida Bandha. It is we are doing in limbs. And Muttoli or Pradoli, Griva Matrio Muttoli. Muttoli and Pradoli are synonymous. Griva Matrio Muttoli. And actually the cervical collar is an improvisation of Muttoli Bandha. Muttoli Bandha, we can do Muttoli Bandha like this. I didn't took video of that, but I will explain what is Muttoli Bandha. We can take circular coverings of cotton with top band or compressed cotton around the neck. Circular turns, 3 circular turns. And then we can place a splint over the both lateral side of height this much. We can place both lateral side splints, 2 side splints like this above the cotton. And then circular turn with gauze can be applied. And then circular turn with gauze can be applied. After applying the circular turn, then it functions as a cervical collar. It will prevent the movement of the cervical spine. Regarding Muttoli Bandha, actually Muttoli Bandha is, we are applying on Griva, and actually it's an improvisation of, the cervical collar is an improvisation of Muttoli or Pradoli Bandha. And coming to the orthosis, usage of cervical collar or lumbosacral corset, this is very important. It should be only used at the initial phase, in the acute phase. After the acute phase, after when pain subsides, it must be removed. If we are advising one orthosis to a patient, it is very important to advise the patient in the very beginning itself when to avoid this particular orthosis. Otherwise, when you apply one orthosis, even kneecap or cervical collar or lumbosacral corset to a patient in the acute phase, then ask the patient to come after 1 week. The patient didn't come or doesn't come after when pain subsides, then the patient continuously uses this particular orthosis for 1 year or 2 years. It causes wasting to the muscles. Actually, the pathology will increase. Whenever that patient goes to other doctor, that patient will explain that doctor gave me this orthosis. So that advise the patient to remove the orthosis, to avoid the orthosis after the acute phase. This is very important while we are advising orthosis. This is actually Muttoli Bandha. Coming to Swastika Bandha, this is a hip spica bandage. Here you can see hip spica bandage. This can be incorporated in injury, transverse process injury, and also it can be given in spinous process injury of lower back, and in acute phase of lower back strain, or in acute phase of sacroiliac ligament sprain, in such conditions, acute phase of disc prolapse, whenever there is acute low back pain, in such conditions also, to give rest, we can give this bandage. This is very effective. This particular bandage is very effective. This can be removed after a period of 3 days to 7 days. This bandage is better than lumbosacral corset. If it's a fracture, we can use Murivanna also over the affected part. Regarding transverse process is situated totally 5 cm lateral to spinous process. We already discussed this in the spine class, and we can palpate that particular transverse process and feel the tenderness, and we can identify the fracture and advise the patient to take X-ray. In such conditions, this particular bandage is very effective. This is hip spica bandage. We are taking 2 circular turns over the trunk and then 2 circular turns over the one hip towards one hip and thigh. We are taking 2 circular turns. This is actually swastika bandha or hip spica bandage. This safety pin is avoided to avoid inward rolling of the bandage. To avoid inward rolling of the bandage, we are giving safety pin. This should be removed in 3rd day or 7th day as per the condition of the patient. The first thing regarding this bandage is it should be inside the dressings. It should be done inside the dressings. After undressing the patient, we are giving this bandage. This is actually hip spica bandage or swastika bandha. If we are doing this particular bandage to both legs, then it's dhamma bandha. If we are giving this particular bandage to both legs, then it is dhamma bandha. In bilateral perthes disease, we are giving dhamma bandha. In dhamma bandha, what we are doing is 2 circular turns over the trunk, 2 circular turns over one thigh, and 2 circular turns over the other thigh also. Actually, when we are doing this particular bandage, then it's called as dhamma bandha. This is swastika bandha or hip spica bandage. It is taken only to one leg. If there is radiating pain to one leg, that particular leg is immobilized like this. Second thing, if we are covering both hips or both thighs with this trunk bandage, then it's called as dhamma bandha. Dhamma bandha is doing in bilateral perthes disease. Sangade ange or Sambade ange. That is dhamma bandha. This is swastika bandha. This is swastika bandha of knee joint. Swastika bandha of knee joint. Actually, this particular material is called as muff. This is very soft. This is muff. Knee bandage should be done in knee flexion. 5 to 20 degree flexion is needed. 5 to 20 degree flexion is needed. This is functional position. Coming to shoulder, a slight abduction is needed. In metacarpophalangeal joint, we are giving this particular position. This is James position. In ankle fracture, or if we are bandaging to the ankle joint, then it is kept in dorsiflexed position, and second toe should be towards tibial tuberosity. We will explain all this in that particular area of bandaging. We are seeing this shoulder bandage, then ankle bandage, or we will discuss. This is also, we apply muff. Regarding the application of muff, actually this muff should be covered 3 covers over the proximal and distal areas. Over the proximal area and distal area, 3 turns are needed. And in bony points also, 3 turns are needed regarding muff, or not muff, regarding compressed cotton. Regarding compressed cotton or top band, it should be covered 3 turns on the proximal and distal, and in all other areas 2 turns are needed. In bony points also 3 turns are needed. In this particular bandage, I am giving a twist over the medial, lateral, inferior and superior aspect of patella. In this particular bandage, in knee bandage, I am giving a twist over the, this is inferior twist. Here you can see. This particular twist is given on medial aspect, lateral aspect, inferior aspect and superior aspect of patella. That particular twisting is giving more firmness or more power to the bandage, give more immobilization to the affected joint. Regarding knee joint, you can use a twisting over the medial, lateral, inferior and superior position. You are taking four tails to immobilize over the proximal and distal part of patella. This particular mobilization, we are tying the knot over the proximal and distal aspect of patella. Proximal aspect of patella and distal aspect of patella. In all bandage, first we are applying a gauze or muff to avoid cotton allergy. To avoid cotton allergy, we are applying either in, if we are doing POP cast, we are applying a stockinette. Otherwise, in simple bandages, we can use a gauze piece or muff and then cotton is applied. Here we are tying on the proximal aspect of patella and then this second is tied over the distal aspect of patella. This is also swastika bandha or figure of 8 bandage. Coming to Anuvilita bandha, here we saw one swastika bandha, hip spica bandage. This is knee bandage. This is also swastika bandha. This is Anuvilita bandha. Here this Anuvilita bandha is on limbs, spiral bandage in Colles fracture, distal and radius fracture, and also in Colles fracture, bimalleolar fracture of ankle. In such conditions, we are doing spiral bandage. Here you can see the reduction method of Colles fracture. In Colles fracture, what we are doing is, I will explain this in detail at the concerned part regarding joints. Here just you can see the reduction method of Colles fracture. In Colles fracture, there is fracture at the distal end of radius within 2.5 cm from the wrist joint, with or without avulsion of ulnar styloid process, with a characteristic deformity called Dinner-4 deformity, and the distal fragment displaces posteriorly and laterally. I will repeat. Colles fracture is fracture at the distal end of radius within 2.5 cm from the wrist joint, with or without avulsion of ulnar styloid process. In 50% cases of Colles fracture, there will be ulnar styloid process fracture, which won't be united. In some conditions, in a small number of patients, there is a chance of tendinitis to this particular area after 2 to 3 years of injury. There is a chance with or without avulsion of ulnar styloid process. In 50% cases of distal radius fracture, there is a chance of ulnar styloid process fracture, and with a characteristic deformity called Dinner-4 deformity. All of you know that Dinner-4 deformity or Silver-4 deformity, and the distal fragment displaces posteriorly and laterally. The displacement is posterior and lateral when compared to the anatomical position. When the hand is in anatomical position, the displacement is posteriorly and laterally. This is the displacement of radius. In clinical DAS, it is written as like this. It is the most commonest fracture. Colles fracture is the most commonest fracture. But in Adams, it is written like that. This is the fracture, most commonest fracture above the age of 40. This is the most commonest fracture above the age of 40. In Colles fracture, what we are doing is traction and counter traction. Here, regarding traction, the hand should be kept in a 90-degree position. The thumb and the other 4 fingers should be in a 90-degree position, and there should be ulnar deviation. The ulnar deviation is for the correction of lateral displacement of radius. The ulnar radiation is for the correction of lateral displacement of radius. I already explained that there will be lateral displacement and posterior displacement to the distal end of radius to the fractured fragment. And to correct the lateral displacement, we are giving this ulnar deviation. In ulnar deviation, we are giving traction. Here you can see that the thumb of the patient should be in directly forwarding towards the person who are giving traction. The thumb is in a straight line with the person who is giving traction. This is regarding ulnar deviation, and 4 other fingers should be in 90 degree to the thumb, and then traction should be given to the thumb and to the 4 fingers like this. Up to metacarpophalangeal joint, there will be bandage, so that while advising traction, it should be from distal to the metacarpophalangeal joint. Otherwise, at the time of bandage, the who are giving traction, he will remove the traction so that it may cause redisplacement of the fractured fragment. So that whenever the traction begins, from the beginning itself, it should be in ulnar deviation, and separate traction should be done for thumb and other 4 fingers. Thumb and 4 fingers should be in 90 degree flexion, and the thumb should be directly forward towards the person who is giving traction. This is the basic principle regarding traction of Colles fracture, and the counter traction should be given on the elbow joint like this. The counter traction should be given on the elbow joint like this. Actually, this is a particular application of murmur. If we are typically giving traction over the, counter traction over the cubital fossa, advise the counter traction giving person to give counter traction over the cubital fossa, then the pain of this particular reduction maneuver will be reduced up to 50%. If we are giving counter traction over the cubital fossa, then the pain of the reduction maneuver will be reduced to 50%. So that surely make sure the counter traction should be given on the cubital fossa, and the traction should be given, the thumb should be directed forwards to the person who is giving traction, and other 4 fingers should be in 90 degree, and the person should give traction distal to the metacarpophalangeal joint. And this is the position of traction and counter traction. By giving ulnar deviation itself, the lateral deviations or the lateral displacement of the radius will be corrected. And the second correction is correction of posterior displacement or dorsal displacement of the, this is counter traction. Counter traction should be applied like this, traction should be applied like this, and then supporting the proximal fragment using the thenar eminence of one hand, using the thenar eminence of other hand, the distal fragment should be pushed downward in this particular position. It should be pushed downward. With the support of the proximal fragment is supported by the thenar eminence of one hand, and using the other hand, the dorsal displacement or posterior displacement is corrected. There is one rule: if the patient's left hand is affected, then you can use the right thenar eminence for the correction of distal fragments. If patient's right hand is affected, you can use your left hand for the correction of distal fragment. This is a basic rule, but it's of not much importance. You can forget that particular rule, but using the thenar eminence of one hand, support the proximal fragment, and using the thenar eminence of other hand, correct the distal fragment which is displaced posteriorly or dorsally. This is the reduction method of Colles fracture. Here you can see we are supporting the proximal fragment with one thenar eminence, and the distal fragment is pushed downward. Likewise, it is corrected. This is the reduction method of Colles fracture. First thing to be done is traction. Second is counter traction. By the traction and counter traction itself, we can feel the disembankment of fragments. Actually, this is impacted due to the fracture and displacement. We can feel the disembankment on traction and counter traction. And then on ulnar deviation itself, the lateral displacement is corrected. For the dorsal or posterior displacement, using one thenar eminence, support the proximal fragment, and then using one thenar eminence, using the other thenar eminence, correct the displacement, posterior displacement by pushing it downward. This is the reduction method of Colles fracture. Colles fracture is very common. We can reduce this like this particular reduction method. And Colles cast is actually, the Colles cast is to be done in ulnar deviation and then on palmar flexion. The Colles cast should be applied on ulnar deviation and on palmar flexion. This should be applied. Here I am showing only spiral bandage. Not in this particular video, I am not showing you the cast video. And whenever there is Colles fracture, I am doing a half cast bandage with one splint. One posterior half cast is applied and one splint is applied on the anterior aspect. Through the anterior aspect, we are pouring Murivanna in the initial phase. If you are not using half cast POP, then 4 splints should be applied. One splint over the posterior aspect from the metacarpophalangeal joint up to the elbow joint, and other splint is anterior from metacarpophalangeal joint to the elbow joint, and other 2 splints, one medial and one lateral, and it should be from the wrist joint to elbow joint. The lateral splint should be from wrist joint to elbow joint. If we are using a half cast, then we can avoid the posterior, medial and lateral splint and we can apply anterior splint. Half cast bandage with one splint has advantage over full cast. Why? Because if we are using this Murivanna, the stiffness to that particular joint is more reduced than complete cast bandage. So that we can provide early rehabilitation and early range of motion to that particular patient if we are using a half cast bandage with one splint. We can also use bandage with 4 splints, but the difference is that if we are giving bandage with 4 splints, rebandage is needed on every 7th day. Every 7th day, we should advise the patient to come for rebandage. If we are doing half cast bandage with one splint, first and second review should be in a gap of 7 days. And after that, we can ask the patient to take 2 weeks or 3 weeks gap for rebandage. Within 4 weeks to 6 weeks, we can avoid the bandage also. The maximum period of immobilization of Colles fracture is 6 weeks. In elderly people, we need more time for the callus formation, but the bandage should be removed early to maintain the rehabilitation, to preserve the range of motion, so that in elderly also, there is no need of prolonged immobilization. Immobilization should be removed whenever at the absence of tenderness. The absence of tenderness is the sign to remove the bandage and start rehabilitation. Whenever there is callus formation, then there will be absence of tenderness. And in absence of tenderness, we can ask the patient to remove the bandage and then start the rehabilitation. This is regarding the management of Colles fracture. Coming to this Anuvelida Bandha, in Anuvelida Bandha, actually we are applying a gauze initially, and then we are applying compressed cotton. Regarding compressed cotton, over the proximal area and distal area, 3 turns are needed. Over the bony points also 3 circular turns are needed. In all other area, 2 turns, only 2 turns are needed. This is regarding circular turns of compressed cotton. And then fix it with roller bandage. This is Anuvelida Bandha or spiral bandage. In lower limb also, in tibia fracture, in fibula fracture, below knee cast bandage are actually spiral bandage. This is Anuvelida Bandha. In this particular injury, we should apply a sling also. This is Anuvelidam Shahasu. Coming to Mandala Bandha, it is circular. More commonly, it is done over head, and in trunk also we can do this Mandala Bandha. Stagika Bandha is stump-like bandage, Angushta-anguli metra greshu. We can correlate it to recurrent bandage which we are doing in amputated limb. Stagika can be correlated to recurrent which we are doing in amputated limb. I will explain recurrent bandage at that particular time. Yamaga or Yamala is double bandage. If there is one wound over this particular area and other over this particular area at the distal end of humerus and the proximal area of forearm, whenever there is two ulcers or two wounds, if we are covering this particular two area with a single bandage, that particular bandage is called as Yamaga Banda or Yamala Banda. Katwa is four-tailed bandage. Hanu Shanga Gandeshu Katwa. Katwa is doing in that particular bandage is doing in mandible fracture and temporomandibular joint dislocation. In all dislocation, we should give an immobilization for a period of 3 weeks. In Katwa Banda, what we are doing is a small piece of gauze is layered in 5 layers. The distance of that particular gauze is from here to here like this. Measure this particular measurement of that particular patient, and then it is divided into two tails. The two ends are divided into two tails, then it becomes 4 tails, and then we apply this particular middle aspect of the bandage over here, and through the anterior aspect of ear and posterior aspect of ear, we are taking the anterior tail and posterior tail, and here also anterior tail and posterior tail. The right-sided posterior tail is tied to the left-sided anterior turn. Like crossing, we are giving that particular bandage. The left-sided or right-sided anterior turn to the left-sided posterior turn. Likewise, we are doing Katto Banda. Katto Banda, very simple bandage. Actually, first we are measuring the total distance, the total area to be immobilized, and then 4 to 5 turns, 4 to 5 layers gauze is taken, and then apply the middle part over here, and through the two anterior and posterior aspect of ear, we are taking that particular tails and then tied over here. Actually, this is Katto Banda, which we are doing in mandible fracture and temporomandibular joint dislocation. This particular bandage is very much effective in this particular condition. China Banda is eye bandage, Abangyo China. After applying Pindi, we are doing this particular bandage. Vibanda is Prashtodala Varasu Vibanda. In rib fracture and in T12 fracture, we can use this Vibanda Banda. Coming to Vibanda Banda, here we can see Vibanda Banda. This is actually compression test to identify the rib fracture. In this particular position, patient should be in seating position and apply a pad over the affected part. If there is T12 fracture, then over the dorsal spine, we are applying this particular pad. The pad should be applied on the affected area and we can pour Murivanna. This particular bandage is very much effective in pain management. In rib fracture and also in T12 fracture, this particular bandage is very much effective. The width of this particular bandage is 30 centimeter and length is 5 meter. For hip spica bandage also, we are taking this particular same measurement, 30 centimeter width into 5 meter. In shoulder spica bandage also, we are taking the same measurement, 30 centimeter width into 5 meter. Three circular turns should be taken. And at last, after taking 3 circular turns, at the end, you should take a turn. After tying, you should take a turn through the cervical area also to avoid slipping of this particular bandage downward. This is typical regarding Vibanda Banda. Ensure that the patient should look straight while doing this particular bandage. When we are taking a cervical turn, ensure that the patient should sit straight. All patients should look down. What is happening here? If we are doing the bandage in this particular position in cervical flexion, after 2 to 3 days, patient will return to OP due to cervical pain. So make sure that after doing this particular bandage, check that whether it is loose or not. Pin should be applied, same as of hip spica bandage, to avoid inward rolling. You can mark the affected part and ask the patient to pour Murivanna in Vibanda Banda. Check that it is loose or not. This turn taken to the cervical area, it should be loose. ensure that it is loose. It may not be much tight, but this particular bandage should be tight. Immediately after the immobilization, patient felt pain relief in rib fracture and in T12 fracture. Immediately after the bandage, patient felt good relief in pain. This is Vibandha Bandha. If we are not taking this cervical turn, then this bandage is called as Mandala Bandha. Mandala Bandha. If we are taking this cervical turn, then it is called as Vibandha Bandha. Vidhana is correlated to cephalic bandage, Murdhini Vidhanam, which we are doing on the head. Nowadays, we are not doing this particular bandage as we are missing head injury, so that we are not in our OPD, we are not doing this particular bandage. Actually, Vidhana is bandage done to head. In Vidhana Bandha, we can use a roller bandage which is rolled from both the sides. From the center here, we can start the bandage, or otherwise we can take anterior turn to posterior turn like this. Anterior to posterior, 3 to 4 turns should be taken like this, and then we can fix it with circular turn. In Vidhana Bandha, either you can use a roller bandage which is rolled from the both sides, and then it should start, the center part should start from here, or we can use one single roller bandage from anterior to posterior like this. 4 to 5 turns should be taken like this from anterior to posterior, and then it should be fixed with circular turn. Actually, this is Vidhana Bandha or cephalic bandage. Coming to Gofana Bandha, all of us know that it is T bandage, which we are doing in perineal area. In ARC procedures, or if there is profuse bleeding, to arrest bleeding, we can use this Gofana Bandha, which is very effective. Panchangi Bandha is 5-tailed bandage. Jitrana Urdham, Panchangi Bandha. Instead of 4-tail, if we are using 5-tail, it is called as Panchangi. In Hanusandhi Vislesha, in Susrudam Chigilsa, Susruda Acharya explained Panchangi Bandha. But as per Sutrasthana, Susruda Acharya explained Hanushanga Gandeshu Katwa. And Ulsangi, as Vagbhadacharya is more practical, he included Ulsangi Bandha, sling or triangular bandage, which is very effective in all upper limb injury. In all upper limb injury, we must advise a sling from the very beginning. Coming to the rules of bandaging, it includes, this is important. Why? Because if we are doing bandage, by knowing these particular rules, then that bandage will be very effective. If we are doing bandage without knowing these rules, some bandage may be effective, other may not be effective. So this rules of bandaging is very important. Coming to the rules of bandaging, correct size of the bandage must be assessed according to the part to be covered. This particular measurement is given in operative surgery in finger and toes 1 inch or 2.5 centimeter width. And we can take a length of 1 meter, maximum 1 meter. In head, we can take 2 inch width. For that, we can take a length of 3 meter. In upper limb, we can take 4 inch. In upper limb, we can take 4 inch. Actually, it is 10 centimeter. Into 3 meter length is needed. This is width, 10 centimeter width into 3 meter length, which can be incorporated in upper limb. In lower limb, we can take 6 inch, 15 centimeter width into 3 meter. In lower limb, we can take 15 centimeter width into 3 meter. In trunk, in hip, in chest, and in shoulder. For Swastika Bandha of hip and shoulder, Spica bandage of hip and shoulder, and for Vibandha Bandha, we can use 30 centimeter width into 5 meter. 30 centimeter width into 5 meter. If it's a small boy, we can reduce that particular measurement. If it is a big person, we can increase that particular measurement. As an average, we can take the measurement of bandages 30 centimeter width into 5 meter length. In trunk, in upper limb, 10 centimeter width into 3 meter. In lower limb, 15 centimeter width into 3 meter. In head, it is 2 inch width into 3 meter. In fingers and toes, 2.5 centimeter width into 1 meter. This is the correct size of bandage which we can use. The second thing is part to be bandaged should be kept in correct position before the bandage. The ideal position of elbow in almost all injury is flexed position, 90-degree flexed position, except in olecranon process fracture due to the avulsion of triceps muscle. Whenever there is olecranon process fracture, avulsion fracture of olecranon process due to the pull of triceps muscle, in that particular condition, it is better to do the bandage in extended position. In all other conditions, it is better to go for bandage of elbow in 90-degree flexed position. We should keep that particular position, 90-degree flexed position, and then do the bandage. You should not do the bandage in this particular position and then ask the patient to keep the hand or elbow in this particular position. It should not be done. The ideal position of elbow in almost all injury is flexed position, but in avulsion fracture of olecranon process due to the pull of triceps muscle, in that particular condition only we are doing extended position. In that particular condition, the bandage should be done in extended position. Elbow should be kept in extended position before the bandage. Coming to shoulder, a mild abduction is needed. In greater tuberosity fracture due to the pull of supraspinatus muscle, greater tuberosity avulsion fracture due to the pull of supraspinatus muscle, the hand should be kept in this particular position, in 90-degree abducted position. This particular position is called as aeroplane splintage. Aeroplane splintage. Coming to knee joint, I already explained that the knee should be in 5 to 20-degree flexion while doing bandage. In ankle bandage, ankle should be in dorsiflexed position, in 90-degree flexed position, and the second toe should be towards tibial tuberosity. These basic things is very much important, and that particular position should be maintained before the bandage. In Colles fracture, we already explained that in Colles cast actually means the wrist is on ulnar deviation and on palmar flexion. This is the third thing. Head of the bandage should be on the outer aspect of the bandage. Head of the bandage means actually a bandage includes head and tail. Tail should be applied over the patient's affected part, and head should be placed in surgeon's hands, and the head should be always on the outer aspect, which means that the turn should be from inward to outward. Inward to outward means it should be from medial to lateral. When explaining the division of Charagacharya, Vama and Dakshina, I already explained that it should be from medial to lateral. One exception is there, that is in patellar subluxation. Patellar subluxation is lateral. Patellar subluxation is lateral. So the reduction method is medialward pressure with extension. And after the reduction, in that particular condition, the bandage should be done from lateral to medial. Why? Because the displacement is lateral. To give medialward support, we are giving bandage from lateral to medial in lateral subluxation of patella. Actually, the patella always subluxate to lateral side. So that in that particular condition, after the reduction method, we are giving bandage from lateral to medial, not medial to lateral. Generally, we are doing bandage from medial to lateral. This turn should be taken from within outwards, from inwards to outwards. First two turns of the bandage should be at same level to avoid slipping. The first two turns of the bandage should be at same level to avoid slipping. And the next thing is equal pressure should be maintained throughout the bandage. In some area, it might not be more tight, it might not be more loose. Equal pressure should be maintained throughout the bandage. This is important. Coming to next aspect. For giving tight bandage to prevent bleeding, a thick pad of cotton wool is applied. This is not regarding injury. To prevent bleeding, a thick cotton pad should be applied to arrest bleeding in all conditions. This is regarding injury. Each succeeding turn should overlap 2/3 of the preceding turn. Each succeeding turn should overlap 2/3 of the preceding turn. And two skin surfaces should not be bandaged together. I already explained that it is better to avoid the next finger as a splint. But in toe, we can use the next toe as a splint. Why? Because there is no functional outcome. There is not much movements when compared to fingers. We can use other toe or the two toes. If the third toe is affected, we can use the second and fourth toe as a splint, and in between we can place a piece of cotton which is covered by gauze. Two skin surfaces should not be bandaged together. All dressing must be properly covered. This is important. All dressing must be properly covered. Tip of fingers and toes should be exposed to check the circulation. If we are doing a bandage in injury or in fracture, always the tip of the fingers and toes should be exposed to check the circulation. After the bandage, we can check capillary refilling test. Within 3 seconds, it should be come to normal color. Within 3 seconds, whenever we are checking capillary refilling test, within 3 seconds, the normal color should be regained. This is regarding rules of bandaging. I repeat it once more. The correct size of bandage should be taken as per the affected part. Regarding upper limb, we should take 10 centimeter width into 3 meter. In lower limb, 15 centimeter width into 3 meter. In trunk, in shoulder, hip, and for Vibhaddha Bandha, we are taking 30 centimeter width into 5 meter. The part to be bandaged should be kept in correct position before the bandage. Head of the bandage should always be on the outer aspect of the bandage. Turn should be from inwards to outwards or from medial to lateral. The first two turns should be at the same level to avoid slipping. Equal pressure should be maintained throughout the bandage. Each succeeding turn should overlap 2/3 of the preceding turn. Two skin surfaces should not be bandaged together. All dressing must be properly covered. Tip of the fingers and toes should be exposed to check the circulation. This is regarding rules of bandaging. And signs of tight bandage includes blue tinge to the fingernail or toenail, blue or pale skin color, tingling or loss of sensation, coldness of the extremity, inability to move the fingers or toes. Whenever there is tight bandage, immediately remove the bandage. If that bandage is kept for 1 week, then there is a chance of medical legal issues. So that this is very important regarding bandage. Let us stop the class here. You can ask any doubt regarding this particular topic covered today.